I'm Dr. Rebecca VanDyke. I'm a professor of medicine and gastroenterology at the University of Michigan in the Ann Arbor VA healthcare facility. Today we're going to talk about diagnosis and management of cirrhotic ascites. I have no conflicts to disclose. This presentation will cover the off-label use of furosemide and spironolactone for diuresis of ascites. Topics to be covered today are listed here, including diagnosis of cirrhotic ascites, complications of ascites, pathophysiology of ascites, treatment of cirrhotic ascites, resistant ascites, and spontaneous bacterial peritonitis. The presence of ascites can be suggested by physical findings. However, fluid wave, shifting dullness, and the puddle sign have low sensitivity, and obese patients hide ascites well. Therefore, confirmation of ascites usually requires imaging. Ultrasound is preferred as it's sensitive, specific, is low cost, no radiation, and readily available. However, CT and MRI will show ascites very well. This picture demonstrates ascites in a cross-sectional CT. The thin arrows point to ascites surrounding the liver and showing the very enlarged spleen characteristic of patients with cirrhosis. The differential diagnosis of new-onset ascites is broad. However, cirrhosis with portal hypertension accounts for about 75% of cases, as shown on this pie diagram. Other causes must be considered, however, and need to be ruled out. Clinical clues to cirrhosis as the cause of ascites are helpful but not diagnostic. For example, evidence of portal hypertension includes splenomegaly, thrombocytopenia, and the presence of esophageal varices. Evidence of liver dysfunction seen in cirrhotics includes low serum albumin and an elevated prothrombin time. However, ascites and thrombocytopenia may be the only presenting symptoms of cirrhosis. The definite approach to the etiology of ascites is shown here. Diagnostic paracentesis is the first step to determine the cause of ascites. First, three broad categories of ascites can be identified by measuring albumin concentrations in both serum and ascites, as well as total ascites protein. You measure the albumin in grams per deciliter in both ascites and serum, then calculate the serum ascites albumin gradient, or SAG, S-A-A-G, as the difference between the albumin in serum and the albumin in ascites. A high gradient, so a difference or a SAG of greater than 1.1, is differentiated from low SAG or a gradient of less than 1.1 grams per deciliter. The interpretation of these gradients is shown on this diagram. If the SAG is high, so there's a big difference in the albumin concentrations, then the fluid is usually coming from the hepatic sinusoids. If the SAG is low, as shown on the right, the fluid is coming from the peritoneum. So with a high SAG, this can be due to cirrhosis, and in that case the ascites protein is usually quite low at less than 2.5, and cirrhosis or late Budd-Chiari syndrome are the general causes. If the SAG is high but the ascites protein is also high, this generally means the sinusoids are normal, and this is due to post-sinusoidal high pressure, which includes right heart failure, causing cardiac ascites, constrictive pericarditis, veno-occlusive disease in the liver, and early Budd-Chiari, and one needs to pursue cardiac and vascular evaluation. If the SAG is low, the problem is in the peritoneum. It's usually peritoneal lymph, pancreatic leak or infection, or peritoneal implants of tumor. The ascites protein is high, and one needs to look for malignancy, tuberculosis, pancreatic ascites, chylous ascites, etc. As shown on this next slide, the third step is using these additional tests to allow further characterization of the cause of ascites. As shown in the yellow on the left, the protein and albumin and the SAG can tell you whether this is most likely to be cirrhotic ascites. Additional tests, including polymorphonuclear leukocyte count, culture, tuberculosis cultures, can suggest infection. Glucose, LDH, TB culture can also suggest a secondary peritonitis or infection. Amylase, triglycerides can provide clues to pancreatic ascites and chylous ascites, and cytology would indicate malignant ascites. So moving on to the complications of ascites, these are listed here. Infections, specifically spontaneous bacterial peritonitis or SBP, respiratory embarrassment, abdominal pain, umbilical hernia, edema, which often accompanies ascites, and pleural effusions, although those are less common. Let's look at the pathophysiology of a cirrhotic ascites and why does this happen? The scarred and obstructed liver causes renal sodium retention through release of catecholamines and activation of the renin-angiotensin system. The retained fluid leaks from the obstructed liver capillaries into the peritoneum. I wanted to touch bases briefly on some similarities and differences between the fluid retention in patients with cirrhosis versus those with heart failure. In both cases, renal retention of salt and water is the primary driving force. In cirrhosis, the fluid accumulates below the obstructed organ in the peritoneum. In heart failure, fluid accumulates behind the obstructed organ, which is the heart, therefore in the legs and the lungs. Edema may occur in cirrhosis, ascites may occur in heart failure. In cirrhosis, diuresis removes ascites slowly, a maximum of 500 milliliters a day, and rapid diuresis, to try to get more fluid off than this, may worsen renal function and cause no success. On the other hand, in heart failure, rapid diuresis improves cardiac and renal function by moving the patient back up the Starling curve and is a mark of success. The treatment of cirrhotic ascites, therefore, is both ideal and practical. The ideal circumstance is to cure the underlying liver disease, not usually possible except by liver transplant. Therefore, we can do large volume paracenteses. This is a temporary solution only, but it's indicated for temporary relief of abdominal pain, large umbilical hernia, respiratory embarrassment, etc. The definitive treatment of cirrhotic ascites with medical therapy is listed here with the key steps. These include a critical component, which is sodium restriction. One must reduce sodium intake below renal sodium output. The second step is diuretics. These are used to increase sodium output above the oral intake. Additional steps, which are very important, is to stop any nonsteroidal anti-inflammatory drugs, as these will decrease renal blood flow in cirrhotic patients and decrease sodium excretion. Fluid restriction is neither necessary nor helpful unless serum sodium is less than 125 milliequivalents per liter. So for treatment of cirrhotic ascites, the first essential key step is to reduce sodium intake. This must be reduced to less than 2 grams of sodium intake a day, which is about 90 milliequivalents. This includes adding no salt during cooking or at the table, the elimination of foods with added salt such as canned soups, frozen foods with sauces, salty snacks, soy sauce, pickles, sauerkraut, anything that's brined. Also, elimination of beverages with added salt, which are basically Gatorade and Powerade. The next key step is diuretic use. We aim for a slow, steady diuresis with a combination of furosemide and spironolactone. The combination works better than furosemide alone. Then you need to monitor for efficacy and for complications following body weight, edema, abdominal size, and for complications looking at the basic panel, particularly electrolytes and creatinine, and a spot urine sodium. Do not use intravenous furosemide to attempt a quick diuresis because it often causes renal failure. The next key step is finding the right drug dosage. Furosemide works in the loop of Henle and causes potassium wasting. The duration of action is short, so we give this twice a day. Spironolactone works in the collecting duct and causes potassium retention. Its duration of action is long. It can be given once a day. We generally start with a mixture of furosemide 20 milligrams twice a day and spironolactone 100 milligrams once a day. This ratio is effective and usually keeps the potassium normal. Then it's important to find the effective drug dosage for that particular person. That means monitoring them every 1 to 2 weeks and titrating up the doses needed. The goal is a loss of about 1 pound a day of ascites fluid, which is 500 mL. If your goal is not met on the first dose, stepwise increases to 40 BID and 200, to 60 BID and 300, to 80 BID and 400, and to 160 BID and 400 to 450 of furosemide and spironolactone respectively can be used, as long as you're monitoring for complications. So the complications to monitor for include low potassium. If so, increase the proportion of spironolactone to furosemide. High potassium, stop any ACE inhibitor or other potassium-retaining material. Increase the proportion of furosemide to spironolactone. If the patient has an increased creatinine, hold the diuretics for a day, restart at a lower dose, make sure they're not taking any nonsteroidal anti-inflammatory drugs, and look for any new infection or GI bleed that could have affected renal function. If patients are hyponatremia to less than 125 milliequivalents a day, restrict their fluid intake to 2 liters a day. Resistant ascites is a problem we all have to deal with sooner or later. This is defined as either a lack of response to maximum diuretic therapy in a patient who's compliant with a salt-restricted diet, or recurrent elevation of serum creatinine limiting use of diuretics in the absence of nephrotoxic drugs or other complications. If the spot urine sodium is over 90 milliequivalents per liter, the problem is non-compliance with a low-salt diet, not resistant ascites. As in truly resistant ascites, the urine sodiums will be quite low due to intense sodium retention. Treatment of resistant ascites includes placement of a TIPS, a transjugular intrahepatic portosystemic shunt. This reduces portal hypertension and reduces the neurohormonal influences on renal salt and water handling. Recurrent large volume paracenteses can be done for comfort, and liver transplant would be the ultimate treatment if applicable and if the patient is eligible. This next slide demonstrates the transjugular intrahepatic portosystemic shunt, which is placed by experienced interventional radiologists. It provides a low-resistance shunt to blood, reducing portal pressure. It will also, of course, decompress varices and prevent variceal bleeding. Lastly, I'd like to touch on the complications of ascites, specifically spontaneous bacterial peritonitis. This occurs as bacteria translocate from the bowel lumen to ascites fluid and there can set up infection. It's defined as ascites fluid with greater than 250 polymorphonuclear leukocytes. Patients can present with worsening hepatic encephalopathy, worsening renal function, abdominal pain, fever, or even no symptoms at all. Therefore, a diagnostic paracentesis must be done in all symptomatic patients who come in with ascites, as antibiotic therapy is critical and life-saving and must be instituted promptly. The diagnosis and therapy specific issues are listed here. First is to send a cell count and differential on ascites every time a paracentesis is performed, regardless of the reason. Second, admit patients with a poly count of greater than 250 and treat with IV antibiotics for at least 5 days. Cephalosporins and other appropriate drugs are listed here. In symptomatic cases, ascites fluid also should be sent for culture in appropriate bottles, although this is less sensitive and takes more time, but it's useful if positive in the modification of your antibiotic regimen. There are also indications for giving patients prophylactic antibiotics to prevent spontaneous bacterial peritonitis. These include patients who have recovered from an episode of SBP. Long-term, they can be given daily a single dose of a fluoroquinolone, for example, ciprofloxacin 500 milligrams a day. In addition, cirrhotic patients hospitalized with any gastrointestinal hemorrhage should in the short term be given a fluoroquinolone twice a day for 7 days to prevent in-hospital infections, including SBP. Take-home points are listed here. Ascites is usually but not always due to cirrhosis. Ascites fluid analysis should be performed initially for diagnosis of the etiology of ascites and whenever any paracentesis is performed for diagnosis of infection. Ascites is due to renal retention of sodium and water. Therefore, treatment depends on increasing renal excretion of sodium and restriction of sodium intake. Although similar to diuresis of heart failure patients, diuresis of cirrhotic patients has some unique features. Spontaneous bacterial peritonitis is not rare, should be looked for with any change in clinical status, and aggressively treated. Thank you.